In the following chapter, I want to give you the rationales why standardization of colon cancer surgery is still missing. And I want to start with this data from Bob Steele from Dundee. And you may see that over the last 25 to 30 years, outcome of colon cancer compared to rectal cancer has changed. In early years, colon cancer patients did better than those with a rectum. But with the standardization of rectal cancer surgery, and probably also due to the implementation of irradiation, if indicated, this was reversed. And one realizes that now rectal cancer outcome is better and better compared to colon. And this is also shown in many registries worldwide that now survival from rectal cancer is better than that of colon cancer. Now, what are the reasons? There seem to be more problems on the right side than on the left side, and the explanation is probably that lymph node dissection, plane preservation, is more complicated on the right side, and surgeons have, due to their experience with rectal cancer now, better experience with a sigmoid cancer. And therefore, this discrepancy exists. When you want to get good information on the quality of surgery, you have to look at the more complicated cases, which are stage 3 or T4 tumors or emergencies. Now, if we take stage 3, you will find in the recent literature relevant differences. So the average of 5-year survival observed is a bit more than 50%. This is in our area at home, this is in Germany, this is with Sears. And on the other hand, there are differences with much better outcome. This is our data, almost 85% 5-year survival, very similar to Japan, but almost twice as much as achieved in some centers. So there is obviously not adequate standardization of lymph node dissection. And again, I show this patient who had local recurrence from inadequate lymph node dissection. And the question frequently arises, does local recurrence with colon cancer exist at all? Is it a relevant problem? And the answer is definitely yes, it is. So Anna Sjöwall from Karolinska in Stockholm mentioned that in their paper in 2006 that local regional recurrence from colon cancer is a significant clinical problem. And there is adequate data to support that. In Myrtle's papers, if you look and analyze all the figures and all the publications, you will find a local recurrence of more than 20%. And you should realize that this was the paper which finally led to the adjuvant chemotherapy of colon cancer. And there are big differences in the literature, but there are even high rates of local recurrence in several papers. And the reasons are that lymph node dissection is inadequate, micro or even larger metastases are left behind, the distance from the transection plane of the mesocolon to the tumor is too small, and multivisceral resections are frequently omitted. So if you tear a tumor, this will lead to tumor spillage, mostly to peritoneal carcinomatosis. With muscular-propria lesions, you get local regional recurrence, but probably peritoneal carcinomatosis as well. And R1 resections are much more frequent than assumed. And finally, most central lymph node dissection is not always adequate. So if you've got a tumor invading the abdominal wall, it is essential to excise the adherent wall with an adequate margin of clearance, not only to both sides, but also on the circumferential side. So you need adequate package. But even if organs are involved, like the pancreas, may it be on the left side or on the right side, or the wall in addition, you have to dissect these organs from the beginning, even if the pathologist will tell you later on that there are just adhesions. But if you try to start with a minor procedure first and open the tumor plane and even add the organs to the dissection later on, you may have killed the patient because the risk of dissemination is very high. So this would be a specimen, a big tumor at the splenic flexure awaiting the abdominal wall and the pancreas. Now these are our data. Local recurrence rate pretty low, or it is highest in stage 3 disease, which means that sometimes we need even more lymph node dissection as proposed by us. Now coming back to the R1, R2 resection locally, not due to distant metastases, but for local reasons. And we know that is much more common than we assume. We have some cases like that in our register too. This is a young lady who presented with a huge transverse colon cancer, a lot of metastasis around the pancreas. And she presented with an acute obstruction, unfortunately even under actual chemotherapy. And I did a subtotal duodenopancreatectomy in addition with a transverse colon cancer resection, and resected the confluence of the splenic and the supramesenteric vein. And despite that, there was a margin involved at the vascular wall. So these are the cases where we experience an R1 resection. So this is our data. Overall, it's less than 1%. R1, R2 is extremely rare, and R1, according to the classical definition, at 0.3%. So these are the rationales why we need to improve colon cancer surgery. In the meanwhile, the prognosis is worse compared to rectal cancer, and this has reversed in the last 2 decades. The local regional recurrence rate is underestimated. Local R1 resections are not that uncommon, and they are mostly related due to inadequate surgical technique. And this all leads to relevant survival difference in advanced cases.